Good morning and welcome to our UBC Learning Circle Practice Guidance to Improve Cancer Screening Care for First Nations Families, a focus on cultural safety and tailored resources with Dr. Kelsey, Louie, and Dr. Unjali Malhotra. Today's conversation is presented in partnership with the Center for Excellence in Indigenous Health, and we'd like to thank the First Nations Health Authority for generously funding the UBC Learning Circle and allowing us to have these conversations today. Before we formally begin, I'd like to acknowledge with respect and gratitude that I'm joining you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Please feel free to introduce yourselves in the chat, and we'll, calling in from the nation that you're calling in from. Whoops. Today's Learning Circle will be exploring practice guidance to improving cancer screening for First Nations families, a focus on cultural safety and tailored resources with Dr. Kelsey, Louie, and Dr. Unjali Malhotra. I'll ask our guests to introduce themselves in just a few moments. For those of you who don't know me, my name is Sarain Squawkin. I'm the Learning Circle Manager. I'm Sealcook-Nongan on my mother's side and Hickory Apache and Belgian on my father's side. I'll be the moderator for today's discussion. Joining us working behind the scenes is Cynthia, our production coordinator, and Kira and Nicole, our production assistants. They'll be in the background interacting with everyone in the chat. Finally, before we get into today's discussion, I'll just provide a gentle heads up that today's topics may be sensitive or emotionally triggering. Please make sure that you're looking after yourself, and if at any point you feel that you need to talk to a friend, elder, counselor, or family member, don't hesitate to do so. We have some prompts in the chat for you if you need additional support. Now I'll turn it over to our guests to introduce themselves.
Thank you. We'll go in the order of how we're presenting maybe. I'm Dr. Unjali Malhotra, and I'm calling in from the beautiful unceded territory of the Syilx Nation, specifically on the West Bank First Nation, where I'm an uninvited guest. And I'm originally from Treaty 6 territory in Prince Albert, Saskatchewan. And I'll pass it off to Kelsey for his intro.
Thanks, Unjali. Checha Hathech. Joshua Jejes, Kelsey Athnan, Menalsultan Athnan, Plaaman Tua, Checha Hathech, Treaty 6, Asna Te Egije. So good afternoon, friends, or good morning, friends. I find myself on the other side of the Rockies at the moment. I'm currently in the community of Edmonton, which I was informed this morning, Treaty 6 territory. So I'm a long way from home, and home is typically in Lekwungen people's territory in Victoria, but my heart still lies in Tla'amin, where I was born and raised, just outside the community of Paul River. And I'm pleased to be here and joining Unjali to try and help present today on some information and some work that we're involved with and quite passionate in trying to support. So pleased to be here.
Thanks, Kelsey. I'm going to slide share and do my best not to mess it up. There we go. So again, good morning. Kelsey and I are fortunate enough to work together in the Office of the Chief Medical Officer at the First Nations Health Authority. And both of us, we have a crossover in our files when it comes to cancer. And so I am primarily involved in the maternal child work at FNHA, and Kelsey primarily in primary care. But we have this great opportunity where we come together on this work. And I think what's a really important piece about when we talk about cancer care, it's really in everyone's work. So, and I think it'll be made more clear as we give this presentation. And I'm just going to try to, there we go. There we are. You already know who we are. So what we're here to talk about today is First Nations cancer and health experience and trends in British Columbia, barriers to accessing screening services, opportunities for improved safety and care, cultural and traditional and spiritual services. And as we like to do at all times, is how do we ground our work in culture and ceremony? How do we ground things in really what's the most meaningful for people in their communities? So we'll start off by going through sort of the side of things where we want to draw attention to something. And I, as an ally, I want to just bring forward that we always want to remember the truth either has been told or is being told to us. And our role as allies is to say, okay, we've heard that truth. Now what do I do? How do I challenge the system? How do I move forward with change within the system? And every big and small way counts. And so what does that look like? Because what we know is that there are inequitable rates when we talk about cervical and colon cancer between Indigenous and non-Indigenous people. We know there are lower survival rates across the numbers of cancers, that we know there's an increase in lung cancer rates, and we know there's a lower overall incidence of people interacting and interfacing with our system between Indigenous and non-Indigenous people. So now, as allies, you know this truth. And now what's the next step? What do we do? Because we also know, as we put together linkage work, so rather than taking just self-identifying factors of indigeneity, we look towards actual linkage work. We look towards saying, going towards more data that really allows for us to know based on status, based on not self-identifying factors, which can be complicated because it can be where someone may not want to identify. Someone might feel that that is not something that's a safe thing to do. And instead, really digging deeper into the data and really seeing what are those inequities and where do they lie. And we are seeing them more clearly. So we know that truth. And then I'm going to sort of haphazardly go through this slide. Whenever someone's coming into care, and cancer is a really important example of this. One of the many reasons that people don't access care are listed on this. So one would be distance to care. And so one thing I always encourage to say is to start to understand someone's journey in getting to you and getting to care, and really committing to that conversation in clinical care. And it is as simple as saying, I'm Unjali. I'm from Prince Albert, Saskatchewan. This is where I come from. This is where I grew up. Where are you coming in from today? And how did you get in to this clinic? What was your route to get here? And because I do a lot of mat child work, we know that at times when we're accessing periodic care and we're accessing care with families, it can be quite a journey to get to care. And it can be quite involved to get to care. And sometimes it can be such a journey that it's a barrier to care where someone just can't do it. It's almost an impossibility. So knowing that is a really important piece, but it's also the getting to know of the person in front of you. What's their life like at home? We want to know that, because how can we give care to someone and send them home without knowing where they're going back to and where they're coming in from? That's vital information. Of course, globally, we have this lack of primary care in Canada. That's an ongoing issue. And coming back to the journey, if it is hard to get to a primary care provider, it's hard to get to their cancer services or screening services, the lack of transport makes that even harder. And that can be something that can be part of that journey conversation. The other part that can be limiting in getting to care would be not knowing to get to care. And so within the pandemic period of time, Dr. Louie and I have, and you can find this on the FNHA website on the cancer page, we did put together a what do you need, why, how, and when chart for folks. And it's in plain English, it's easy to read, and it's a chart. And it's the average risk screening chart. And so just allowing that information to be shared with patients in an easy, readable way has been really important, because a lot of people just don't know why and how and when to come. And then we keep changing it within our system and making it even more confusing for people. Because then there's this middle piece, and there's a lot to this. So we know that a lot of people are not accessing care because they don't feel it's safe. And it at times really isn't safe. People can be greeted with racism. That can be their introduction into the medical care system. That can be their ongoing experience within the medical system. And I do a lot of work on consent and coercion within our healthcare system. And one of the most common things that I hear is someone in my community or I experienced coercion within the healthcare system, and I don't want to then have that happen to me, so I'm not going. So one thing I just want to, I had warned Kelsey before this, and I'm going to go into some stories here, but so I grew up in a small place in central to northern Saskatchewan, and when I was growing up around high school time, there was a really tragic accident that occurred, and lives were lost in this accident. Now, the site of that accident to this day, now 30 years later, because I go home a lot, anyone who drives by it, it's memorialized, that site. And what happens is people slow down and they tell generations about it. They tell other people about what happened. And it goes on for decades and decades and decades. So I urge you to consider healthcare trauma in a similar light. If someone has a traumatic experience with the healthcare system where they thought they were safe, they're going to pass that story for generations to come. And that's how that ripple effect happens, where people then just don't access care. And it can be community-wide. And this fear and distrust of the healthcare system that is rightly based grows. And we as allies, now we know this, need to change the system. We need to move toward what can we do to shift it? What can we do to make places safer? And what can we now say to people that have been generationally impacted by what has occurred, that we want to make this a safer space? And that's work on our end that has to happen, particularly as allies. We have to rise to the occasion.
Unjali, I can,
yes.
If you don't mind, I'll step in that
please.
slide.
Yes.
We can go back to that slide for a second.
Yes.
It makes me think of two major areas that were actually just brought up here recently at this conference that I'm currently at. One of them, when I read, the distance to care, the lack of primary care, transportation issues, travel, accommodation, I think, a lot of people in the healthcare system are sort of speaking about the impact of COVID and what remains to be seen in terms of the consequences from having your healthcare disrupted during the last several years. Not having access to your regular provider who you used to try and go and see, who would try and keep up with screening and annual sort of lab work or check-ins, with your primary care team. And it created new distances. Sometimes some of the providers used to be able to come into some of our communities, but not just our communities, other rural communities at large. And sort of our society is going to wait and sort of see what the impact of that is going to be. How many people did we fall behind on in terms of our screening, in terms of their health and wellness? What are these consequences? Are we going to have delayed diagnosis when it comes to cancer and other conditions that people have? And, when this comes up, I kind of think our Indigenous communities have been faced with this far before COVID came along. This is now sort of the rest of society kind of opening up and saying, oh, that was really a disruptive time. I wasn't able to see my provider. What's going to happen with my care? What's going to happen with my health and wellness? And we hear from our community members, oh, well, this isn't new. COVID created new ways to try and think of it and trying to connect. And we've gone through that. And there's, I think later on, we'll sort of speak of telehealth and sort of virtual services to try and help connect around this. But this is an issue that, our society is going to be faced with, but it is not new to our community members by any means. Oh. The other piece, when I look at the very middle, the green, the distrust and the fear of the health system, or as you alluded to, people's past experiences. One of the questions that they've posed here is, what is the most important thing when it comes to primary care? And one of the things that came up was access to care seems to be a major issue for everybody here. I'm in Alberta, so they say for access for Albertans to primary care is an issue. But they've then since heard, once I'm connected, once I get my foot in the door, I receive excellent care, and it makes me think to the stories we hear from our communities. Access to care is a major issue, but getting your foot in the door doesn't necessarily account to excellent care. We see that's where we fall through a lot of the the racism that's experienced, the discrimination that's experienced, the bad outcomes, the poor sort of journeys that people have. So in our Indigenous communities, we kind of have a dual threat, if you will, not just access, but once you receive sort of your foot in the door, hoping every door is the right door, how is that experience then sort of portrayed? And that sort of speaks to me like the kind of the green box here, and maybe touching on some of the others. So just wanted to kind of follow up on that. Thanks.
Thanks, Dr. Louie. Yeah, we have heard from so many what you're saying, and we have to now say, we know that's the truth, and we have to work towards changing it. We have to work towards creating a safer environment. Because just right back to growing up, where I grew up, people would travel great distances to see a primary care provider. And it can be in many forms. It can be a bus, it can be many people in a car packed in trying to get in. And then when they go somewhere, what happens then? And it would be interesting coming to really safe clinics, which I can proudly say, you know, my parents and others, where then everybody wanted to be seen there. The whole community would come, and 7 or 8 people would be there for one person's appointment, and everybody needed to be and was seen at many of these circumstances, but didn't feel safe then leaving it. And I can bring this back to some of the work we've done on the HPV project as well, where people felt safe coming into the work that I was with, because I was in the community, and it's the community that they live in. But then when we needed to send them elsewhere, so an example would be the colposcopy referrals, many didn't feel safe leaving and didn't feel safe going. And it could have been that they had heard a story about someone or been a part of bad experience within that, or that they themselves just had too many times where they have left good care and got to unsafe care. And it was so profound. So I thank you, Kelsey, for bringing this forward.
Yeah, and I want to allude to the fact that I think both Unjali and myself have spoken about, you know, your primary care teams, your primary care provider. We recognize in sort of our work, it can very quickly become physician-centric. And we recognize in our communities, it's not physicians who typically are in charge, or, you know, sort of the top of the hierarchy, so to speak, but it's really it's our community members. It's the leaders in the community. It's our health directors. It's the nurses who support. It's the homework. Like, it is very much a team-based care type of model that is not physician-centric. So we you know, mindfully and purposefully try and speak to, you know, primary care providers and the teams that support, recognizing, you know, that's more or less the realities for many of our community members, is that it truly is team-based care. We're not necessarily led by a physician, if you will.
Yeah, it's a great point that you bring up, because every time that anything comes forward in particularly in the mat-child world, the first question is, well, what does community want? What has community asked for? So an example would be someone wanting to come into community and either access stories or voices or research or whatever it might look like. Does community want that? Does community want you to be welcomed into this? What's you need to ask? You need to be a part of community, get to know. And this is a big part of us as servants to our work and our populations. We need to know our communities to be able to serve. We need to be knowledgeable and able to ask within our communities. And that's a really, really important piece here. And that is trust building. And that takes time and effort and energy that we have to put in. We wanted to highlight a couple of important pieces that you can find on the FNHA website. So Sacred and Strong is, it was I think it took us about 3 years to put that one together. The First Nations Women's Health Report. Now, what's really unique about Sacred and Strong is that it's story-based. And just as Kelsey had just aptly stated, it's community voice. and so bravely coming forward and telling stories and offering wisdom to make us and our healthcare system better. And I cannot encourage you enough to read this. It's easy to find. It's on the FNHA website under the OCMO page, and there is just so much there. And one of the pieces that I talk to a lot towards is that a lot of First Nations, particularly women, do not access care because of lack of cultural safety. And it was stated time and time and time again. And it really goes back to what we were talking. And then the BC Cultural Safety and Humility Standard. And it's important for us always to remember there's no standard or guideline or course or certificate that one can attain to become culturally safe. It has to be through reflection. It really has to be a lifelong process that we're all on. We're all on a journey. And it involves, at times, hard conversations with ourselves, our peers, our system. And it's really that really meaningful reflection that's required as a constant. As one of the things we've heard is very much so that when we talk about cancer screening in particular, one of the main reasons is not getting cancer screening was feelings of fear or discomfort. So feeling like it's an unsafe space, that it's an unsafe thing to take part in. Now, this is like a big part of the work that is in my pile in particular. When we talk about when someone is interfacing with our system, what does that look like? And one of the important pieces is, of course, trust building that we've talked about a little bit today, and relational care, and making sure that we have time and space for introductions and check-ins. And that comes back to that point of, hi, I'm Unjali, and this is where I'm from. Where are you coming in from? Getting to know your community, knowing your community, knowing the people that you're serving, and being a part of your community. And, it's to the point where, we want to walk away from that sort of doctor piece where we feel like we're separating ourselves from clients and we're separating ourselves from the communities we serve. In fact, we want to be a part of the communities that we serve, and we want to be human. We want to be someone that someone can feel comfortable around and confident that they can trust them, that it's a friendly conversation, it's a friendly experience they're having with someone. It's better for both parties. It's better for the relationship as a whole, and it's better for building teams within systems as well. And then one of the things I wanted to bring up today too is, so within all of the teams and the work that we do in our systems, one thing that I consider like a living, breathing part of care are the forms that we ask people to take part in. So as much as we sort of look at these forms and we say, they're pretty innocuous, they're fine, they're okay, they've been vetted, they're clear, most of them aren't. And I always bring this back to one more story here, metaphor here. When we enter the healthcare system and we're entering it as a non-healthcare person, we're entering it like a city. Like we're going into a foreign land without a passport and without directions that are in a language we understand. So all the street signs and all the highways and all the roads and all that's occurring is like this, it's a different country that speaks a different language. And we always have to remember that, because when someone comes in, that is essentially what they're encountering. Where we feel super comfortable in it and we say everything's working in a way that we're aware of and we understand, it generally isn't the case for someone entering into the system. And it's really important for us always to remember that. And so when someone comes in and they're reading forms and they're going through, consent forms for screening, they're going through pamphlets for screening and things like that, it's important for you to know your community well enough to know, is this something that my community is going to understand? And is it going to relate to my community well? Is it going to be something that people feel comfortable and confident with? That they're actually not just signing because they think it's probably okay, or they feel that they have to, because they're in the system and they feel that there's a degree of, whether it's spoken or just inferred, pressure to do so. How does that feel walking into it? And I encourage everyone to, in fact, take a friend or a relative who isn't a medical personnel and walk that journey within the healthcare system that you're offering and see how they feel. So I think it's an important check-in for all of us to see, did they understand it? Did they get it? Because most of us travel in a circle of other people who understand it, but it's important for us to do those check-ins to make sure that that's not always the situation, because that's not always the situation. Because we want to make sure everything we're doing is patient-centered, that it's coming from community, that's coming from the person who's receiving the care. Because it's important for us always to remember that our system was not built for those receiving care. It was built for the giving of care, not for the other end. So I think we should always remember that our system was not actually built for people to understand it. That's not how it was structured. And so we always want to remember that it's our job, particularly as allies, to counter that, to resist that, and to say that's just not the way that I'm going to operate in my field of practice. And every big and small change matters. Making sure that things are culturally grounded and that you have supports in place and that you are providing training and assessments. However, again, always remembering it comes back to reflection, that we always remember that we can't attain a culturally safe place without the journey of cultural humility, that we have to continue our journeys of reflection to get to a safe place where there is no racism and discrimination, where there is no unsafe feeling within the system, and that people feel that the care that they are receiving is for them. As we do a lot of extraction-based care within medicine, we take histories, we ask a lot of our patients and our clients, and we ask a lot from the people within the system that are receiving the care. But are we actually asking them what kind of care is that they're able to receive? Are we asking community what they want? Are we questioning that whether the care that we're offering and supplying is in fact the correct care for this community member? Because what I really want to pose, and then I'm going to pass it to Kelsey in a very uncomfortable moment of, what if someone's desire to receive care is not what you are able to offer, or that you want to offer based on what you've learned in the Western medical system? How does that work within your system? And these are the kind of questions that need to be posed, because it's, what does your community want and need? And now I'm going to pass it to Kelsey.
Thanks, Unjali. And that often is the concept that we sort of look at in terms of two-eyed seeing, taking Indigenous knowledge and teachings and applying it with one sort of lens, combined with what we learn in the medical world in terms of Western medicine, and trying to blend both of those to sort of create the best sort of situation and experience possible. And so with that, moving on here, in terms of the cultural safety resources, for ongoing learning, it was alluded to earlier, this is a journey, right? It isn't necessarily a checkbox and you do one course and, you pack it in for the year and you're good. We see this as a continuum, and in the ability to try and reach out to different ways of learning. Some of these are didactic, some are experiential, some is just sitting amongst and within community, and getting to know and build those partnerships and those relationships. Some of the work that I was involved with over the last year or so was with a great committee who was tasked to try and support community and primary care in terms of cultural safety and humility learning. So we kind of recognize, in BC, we've got our health authorities who are doing much of this great work, which is fantastic because it ends up being a bit more geographical, right? It's a little closer to home in terms of the teachings. We see on this list, there's the SANIUS, Indigenous Cultural Safety Training. for all intents and purposes, it provides a nice little background to a lot of this work, a bit of the context and sort of the historical means, but it's a little bit across the country, and there's certainly gaps, and there's mislearnings there, and we find, people want to know who's in my community, who do I connect with, or what's sort of in my geography, what's in my region, who are the communities who reside here, how do I learn that? And so the health authorities are stepping up and trying to support some of that work. We've got partnerships with UBC, who are also implementing this within the curriculums in the education system, and many others. But we kind of recognize sometimes some of these programs are accessed within a hospital, within a regional health authority. So what do you do when you work in community, when you're independent from the hospital, you're not connected? How do you tap into some of these resources and programs and courses? So there's a real need to support that voice as well, and those learners, and whether we link them into bigger structures or more local, community-based teachings and learnings. So this is just a list of some of the resources that exist, through our FNHA website. There's some information there. There's new standards that have come out, and lots of this great work that's shared amongst many of our partners, but also within FNHA and within our communities itself. Next page, please.
Oh, sorry, Kelsey. Oh, now I'm not even doing a good job. Here we go. Did I skip?
I think we skipped a couple.
There,
yeah. And Unjali, you spoke to this earlier in terms of how to try and create, safe space, some comfort. This really speaks a lot to trying to empower the patient when we speak of it being patient-centered. How do we let them know they're in control of their health and wellness journey? And so, these are just some practical examples in terms of what one may do or consider doing. And I know, when it comes to BC Cancer and sort of the screening programs, we've been working and partnering with some of our BC Cancer colleagues, and they're now creating, forgive me, I'm not going to know the official title, but essentially Indigenous liaison workers within each of the major BC Cancer sites. And we recognize a lot of the regional health authorities are supporting this with Indigenous liaison workers and patient navigators within the systems. There's, for a lot of great reasons, they are very supportive and receiving a lot of great feedback in terms of the support they offer to navigating the system for many of our community members. At the same time, they can't be everywhere all at once. And sometimes, from an HR perspective, we don't have them filled, 24/7 in each of the hospitals. And we know patients are going to encounter the acute healthcare system at all times. So there are some shortcomings there. But really just trying to work through in terms of, yes, you can bring friends to appointments. Yes, it's okay to ask questions. And this really comes on, when we try and speak about the resources and the cultural safety humility training and that ongoing continuum and a journey, to help be aware of what the patient is coming in with, what maybe their background is, or the larger background in terms of, colonization and those impacts that still carry through to today. And that mindfulness and the awareness of that, we often say, check your ego in at the door and try and approach it, as a mutual relationship. Because we know, from a Harry Potter side of things, sometimes as physicians or primary care providers and specialists, we get caught thinking we have a magic wand and an invisible cloak, and what we say and what we do, or what we prescribe and what we write down and what we sort of advise on is the be all end all. And we know that doesn't have great outcomes for patients. We recognize there are more components to one's health beyond just the physical health, and acknowledging and sort of creating that space to allow for other modalities or just other thoughts in terms of how people want to approach their care is just as important. So,
Yeah,
next.
one thing I just want to
Oh, go
add
ahead.
to that, Kelsey, is I just would direct folks to take a look at some of the blog posts that our office has put out on the FNHA website. And one in particular that's kind of two that are coming to mind right now are related to pap smears, for example. And one was a rights blog that we put out last year about what are your rights when you go to a pap smear. And it was really human rights, that you have the right to bring someone with you. You have the right not to change right away. You have the right not to do it in the first appointment. You have the right to your results. Like these kinds of things that, again, it's a translation of the system of what is actually allowed to happen in these appointments. And in fact, you're in charge. You as the patient are in charge. So giving back that power and making sure it's there, but also one that we did on nurturing spirit, where, you know, what do you need in these appointments? Because that's okay. And that should be respected. And that should be a part of your care as well. So I just wanted to highlight those posts.
Yeah, I think that's a really important perspective to take, particularly on the provider side of things. You know, sometimes the models we work within and the structures, you know, the way sometimes we're compensated drives us to behave in such a way where it's, what do you mean you're not going to undergo the PAP today? Like you want to put that off. Like now I got to reorg. How am I going to do that? Like being respectful of, okay, this, you know, the patient's journey. And if this is ultimately what helps them feel safe or get them to a good outcome, then I want to be supportive of that. And so it's sometimes a bit of a changing of the way we think with regards to this. So this out of the same thing, out of the some of the work we've found here, this diagram, so 33%, and this was, I believe, in the Sacred and Strong that this came out, 33% reported that healthcare workers were never open to hearing about traditional medicine. Didn't even think about it. One in three, essentially. And then, you know, further to that, 30% reported that their cultural traditions were never appreciated by healthcare workers. So I think it's on one aspect trying to create the space to allow for different modalities and different perspectives that people want to bring in terms of their care. So simply asking about it, trying to create space, trying to understand it to a certain extent. You know, maybe we don't fully appreciate or understand, but if it's important to the individual or the family or the community, how do we best be supportive of that? And this is kind of an interesting, it brought me back to perspective, you know, I want to say many, many years ago when I was a learner. I'm still a learner, but before I kind of finished my medical training, I remember one of the more prominent experiences I had was with regards to palliative care and going out into the community and visiting some folks in their homes who were nearing end of life. And I remember working with a really great palliative care physician. And I think in general, you know, a lot of, you know, I'm just stereotype, a lot of palliative care physicians are very empathetic, really try and sit and listen and be very supportive of not just the individual, but also the family as well, recognizing that. I remember going to see someone and I recognize, you know, in where I grew up and how I've understood traditional practices in my community and in my family, there's certain practices around end of life. And when people pass, there's certain ceremonies and protocols that are followed. And that's very different than, you know, what might happen up and down the coast and as I move interior and across the country, recognizing, you know, all First Nations don't share the same beliefs, don't share the same practices and traditions. We may find a lot of similarities and things that way. But during my palliative care rotation, we went out to a family, and I remember, I believe they were a different ethnicity. I can't recall what it was. But sitting there and, you know, I was a learner, I was really timid and didn't know quite what I was supposed to ask. And I was there on a rotation to try and learn from the palliative care physician around end of life, you know, conversations and then the process, kind of the management and how to really keep people as peaceful and comfortable as possible. And I was granted some time to ask some questions and sort of explore some things. And I remember one of the questions was something along the lines of, I'm kind of just curious, are there any particular beliefs or practices or things you would want us to know that we can try and help support, or that would, be important for us to be aware of during this time? And they, kind of maybe a little shocked. I was like, oh no, did I say that in the wrong way? Like, I didn't mean any of it. And they took them a few moments and they said, it's a very thoughtful, really appreciate it. No, there isn't anything in particular that we should know. I was like, oh, great. And I remember after we sort of went and the palliative care physician sort of debriefed with me and was like, I've never heard anybody actually ask that question, or, phrase it in such a way. And, I was like, well, I don't think my head's getting any bigger. It's not like a big ego. I just know where I come from. There are particular sort of practices, and I don't think anybody would know. A regular provider or anybody in this situation wouldn't really appreciate that, but it's really important to, my family or the practices that we have. And I think just kind of opening up those questions to try and explore if there are. And like I say, I may not understand it. I may not fully appreciate it. Nor do I think I need to necessarily, because it's something that's important to the individual and the family, and sometimes the community. And I think that's really important in terms of building that trust and really being supportive in terms of the care. So when we sort of hear some of these, 1 in 3 roughly, maybe even entertain asking a question of that, sort of concept, or actually, if you do, following up further in terms of how do you document this, and how do you kind of carry this forward and maybe apply some of these teachings and learnings to other patient encounters.
So important, Dr. Louie. I know, coming from a family that we have ceremony for everything, birth, death, life, everything in between. It's something that I felt really important in the Mat Child world to put into a lot of our forms. So I bring it back to those forms that we have, that we're giving to people. Remember that they need to represent people's values. And so remember, they're a living, breathing piece of work that I urge you to revisit and have these kinds of conversations within, at least mention, or that it ends in your context of conversations that you're going to have with people.
So the priorities and practices vary by person and community. So this was actually a part of this. The care from an elder, a traditional healer, a sacred knowledge keeper, or other spiritual leader. So recognize there are multiple beliefs, there are multiple approaches and ways that Indigenous communities may or may not want to proceed with work, and ways to support it. So, and we recognize you may be a multi-faith care provider. There are other ceremonies. I was quickly put into perspective during a conversation about a month ago with a knowledge keeper while I was over in Vancouver. This individual said, I experienced going into the acute care system, medical problems in terms of kidney health, and has been on top of it, but required to go into the hospital for a short period of time. And while they were there, they asked, we have an Indigenous liaison worker here. Would you be interested, or is that something that, you would want to have involved in your care, or just be a support to you? And he kindly agreed. Yes, I wouldn't mind that. I'd like that. It'd be quite nice. A familiar face. He said a young Indigenous woman came in sort of the next day or something, and politely greeted him, and it kind of went through making some initial connections. And in it, had sort of paused and said, is doing a smudge something that would be important to you? Can I help you with that? And he kind of sort of chuckled and said, I think I appreciate where you're coming from on this, but he's like, it's not in my practice to smudge. I do a brushing with cedar boughs. And it kind of, he stepped back and he mentioned to me, we are trying to inform the healthcare system providers, those who support our people throughout any encounter that they have, to provide, culturally safe care, patient-centered care, to be very supportive. He said, it doesn't stop there, though. We also need to educate and inform our Indigenous people who work within the system, because we do recognize we come from very different geographies with many different practices and beliefs. And he's as simple as, something where being offered to smudge, I appreciated where they were coming from with it, but he was like, I don't smudge, and nor should I think you assume that that's what my practice would be. So part of that is maybe just in the communication or how the question is asked, more exploratory as opposed to, kind of narrowing in on a particular question. So, this is shared work, and we kind of say, we're all in this together. And that kind of sort of speaks to that sort of aspect. That was one of the teachings that he provided me that day. I appreciate that. And I kind of follow that now. And when I see this, that's what I kind of think of. So that we recognize there are lots of different ceremonial pieces and ways that we, as Indigenous people, we try and approach a lot of this work. And like I say, some people don't have those beliefs. Some people have been sort of disconnected from community. So on the same sort of side of things, just not assuming, but being, inquisitive and just kind of asking and trying to approach it that way in a good way. Oh, thank you. Next page. Sorry, can we go back one? I think we skipped over one. Yeah, so exactly. And this is what sort of just alluding to the exploratory kind of questioning and just the inquisitiveness, trying to create that safe space and just sort of approaching people. And like I say, in that palliative care experience, I didn't know if they had certain practices or beliefs or things that I should know. And but I just wanted to kind of offer that space, that if there was something that would be helpful for the team, that was important for us to know. And I know that's not just in that. We sort of speak about this with birth planning, sort of family planning, those kind of conversations as well. What's important to people? How do they sort of see their journey? And if we can support it as best as possible and sort of stay on track, that's going to be, much more, I think, a better experience for those who are kind of going through it. So we can move on. And sorry, one more. So in terms of the wellness resources, we've listed just a few places where we can look into some supports. So I know some people ask questions, how do I get connected? How do I reach out, or how do I track down some of these supports? So we are mindful that there are many fantastic knowledge keepers and those who have local knowledge who really help lean into a lot of this work to support us. We are mindful of what we kind of refer to sometimes elders fatigue, knowledge keepers fatigue, going back to the watering hole too many times. So there are a lot of work being done in terms of creating a knowledge keeper sort of network and other resources, so that we may kind of share some of that work. And thankfully, most elders won't say no to a lot of work, but we do try and place in the back of our mind, if we keep going to the same person, we try to explore, is there somebody else we can reach out to? Is there somebody else, and I don't know anything about how knowledge keepers and elders groom one another and support and mentor, but you can kind of see how locally around the province, we have 203 First Nation communities. And each of those will have their own local expertise. So it's trying to make the connections there to help support. And, we have within FNHA our regional teams, and we have some of our community engagement coordinators and the supports who might have some of those contacts and knowledge to help support that. We have our Aboriginal Friendship Centers who offer a lot of the same services and supports, who are also a great resource to supporting this. There are cultural supports, Sultan Laylam, and some others listed here as well. So we try to help support and facilitate those connections. And like I say, a lot of them regionally or locally are really great resources, and hopefully can help facilitate meeting some of those.
Yeah, and one thing that we did an HPP project, and you find the infographic on it. I think it holds a lot of what we've talked about today in it. But one of the things that we did was at the health center, we said, who would want to say and what's happening before we started the project? And we asked the health director in the community to bring people together for a meal and have a discussion about what we wanted to have place in the community, and if it was going to be appropriate or not, and whether it was welcome or not. So,
so in terms of some of the programs and resources, we through our health benefits. So there's a First Nations health benefits program through FNHA with, I believe, an email and a phone number that's listed there for community members, providers, and others to loop into. We are working around quality care and safety. So same thing around some of the care, the safety, trying to capture, the stories of people's, experiences and journeys. Same thing. Hopefully we're working towards, and we hear it at times, positive experiences. We still hear negative experiences that come through, and trying to elevate and, listen to understand, and then work those through the system to try and support, complaints or poor experiences. But we're slowly starting to hear, change. And again, I go back to another elder who I'd spoken to, who, in my lifetime, never did I think I was going to go be admitted in a hospital, go through the course, and then be discharged, and it not be a negative experience. There was multiple touch points throughout their care journey in the hospital, and sort of to step back and hear, an elder speak around that fact, that we're starting to see some of the impacts from, I think, a lot of our work, but from what a lot of our communities and leaders have stood up and loudly called upon our health system and those who work within it to make the journey a safe one. We have a very long way to go still, but we're starting to hear some of these success stories, and it makes me think, I end up being optimistic, I end up being hopeful that we're continuing to work down the right path, but we still have a long way to go. One way that we've also tried to connect in with our community members is through the First Nations Virtual Doctor of the Day program. We also have a partnered substance use and psychiatry service as well. We kind of mentioned, some of those obstacles in terms of the barriers to screening that we had mentioned, the travel cost, the lack of access to a primary care provider in the community, things that way. So during COVID, one of our programs, and we have it, physicians who are located around the province in each of the health authority regions, supporting through primary care, that's done virtually. And this program, I think, is, I've been a part of it and have had, again, lots of great feedback. It doesn't replace, that in-person care, but we've had the opportunity to support with the hiring of Indigenous providers, our allies who have worked in communities, who have gone through cultural safety humility training and continue to advance their knowledge and work in this space. Being able to connect in with community members sort of where they're at, which may be rural, it may be urban, just to offer a different sort of resource. And also in terms of some of that supportive team-based care, having some of our community members and those who work within the communities be able to connect in as well, to try and provide some of that wraparound support. So we hear from diabetes nurse educators, some of the nurses who work at the nursing stations, other allied healthcare providers, because we recognize one of the issues that we often have is, if a community member comes out of community to receive care, maybe they're in the hospital for a period of time, they go home, there's often not a great transition back home in terms of that team who supports the individual back home. Not being clear on the plan, maybe not having access to the health authority sort of records. A lot of the way things have been structured is physician to physician contact. And we recognize in communities, we sort of alluded to earlier, we don't really have a lot of the primary care providers who live within community or who are there on a regular basis. So our communities have had to really work diligently over the years, more with less. Has really been a concept that we hear a lot. So this program has been one to help try and connect with people, like I say, wherever they may be. And it's certainly not the be all end all, but it is helping to fill a little bit of a void. And we've heard fairly good feedback from those who have utilized the service thus far. Next slide. So we alluded to the Indigenous patient navigators. I think I was going to incorrectly state their name, but maybe I got it right. I don't know. So we've been working, Warren Claremont and others within BC Cancer who have really taken the lead to try and support the aspect of care in terms of Indigenous people engaging with BC Cancer and health and entering into that health system. Once we've sort of identified hopefully through screening, like we say, sometimes we have these late diagnoses because we haven't had access to screening. So we're now kind of finding people who have the pathology who need to undergo cancer treatments and other modalities. It's another big sort of scary world that you walk into with, a lot of really big medication names and complicated sort of diagnoses. It's not as straightforward as, you have congestive heart failure or you have a broken femur. You're starting to get into some complicated things. And when it gets complicated and sort of scary like that, it is a really great resource to have somebody who can help navigate, help interpret, help support our community members as they move through that system. So they've done a fantastic job to support these in each of the major centers and continue to try and support and expand that team. So it's the burden is not felt solely by the team, but that it is shared within BC Cancer. Next slide, please. Again, some of the resources and connections. So with wellness, we've got a wellness daily organizer, traditional food facts sheets. Many of these can be found within the FNHA website. Our mental health and wellness team, like I say, very much involved in a lot of this work. And there's the CUS, the support line, and other mental health and cultural supports. Same thing for many of the First Nation members within British Columbia, having access to mental health counseling, those services. There are providers who do the direct billing that are located on the FNHA website as well. So community members have access to be able to, self-refer and take a look at those who do direct billing. So patients don't have to pay up front and seek reimbursement, but instead can go in and the provider themselves will do the billing in the back end. But you can, I often encourage people, take a look at the list, start Googling some names. There's often a little bit of a website or a little bit of the philosophy or background in terms of what kind of counseling people do. And there's, ample supports that I've met many patients, through the Doctor of the Day service who have 2 or 3 different counseling services, seeing them at different frequencies for different reasons, but it's complementary care for them. So just kind of alluding to that. And then the respecting tobacco. So there's a video there as well as some other information. Next slide, please. Yeah, so I think Unjali spoke to or just mentioned the average risk screening chart. So again, just trying to, in terms of, I think, education and health literacy, supporting and trying to simplify, kind of through, some people are very good at being at listening and understanding words that way. I myself am more visual. I need to kind of hear it, but also see it, and have some time working through it. So we've tried to create some documents and others that some of our community members have been able to access through, like I say, some of our nursing stations and other places where we've found some of these charts being utilized. So some of these exist on the website. We've worked closely to adopt a lot of the work that's come out of Ontario in terms of their cancer work. So same thing, just looking to create more information that's hopefully easily digestible. It comes in different forms that, like I say, some are more visual, some want to see videos, some want to have the ability just to read. So coming out with a lot of different ways to try and provide those resources. And the cancer screening campaign. So through the First Nations Health Authority, so we had a Gathering Wisdom a few years ago, and Gathering Wisdom helps bring together community leadership, many sort of chief and councils, if you will, from the local leadership, but also the health directors, to join in on a few days of concentrated conversation around healthcare with regards to the health and wellness of our First Nations within BC. And a few years ago, we had a big screening campaign. And I remember this vividly because there was a giant colon, an inflatable colon about the size, it would fill to the roof. And I remember somebody from FNHA asked, Kelsey, can you stand at the colon and just answer questions and try and, gauge people's interest? People come by like, what is this massive, inflatable thing? Oh, welcome. This is the inside of your colon.
You did a great job.
You kind of walk through this gauntlet of a colon and you kind of see, what's supposed to be relatively normal, healthy tissue on the inside, what a polyp might look like, what a cancer might look like, and just generating the conversation. But we had a big focus on screening and the importance of it. So, communicating that to leadership, but also to the health directors and those sort of working within the communities, and trying to open up the conversation, because we sort of, like we say, we're doing the data linkage and really trying to hone in on what the numbers are like, what the disparities might be like. Are we catching cancers at an early stage, or are cancers being caught at a later stage? What does this all mean, and how do we then take this data and create some conversation in terms of how we address it? So we had a big screening push a few years ago that was really led out through one of our Gathering Wisdom gatherings, I guess, a few years back, and looking at coming out with another screening campaign here shortly. So we're just getting to the final ends of that preparation, and you'll probably be seeing a bit more of us and many of our colleagues who have been working really hard on this work. And that's about it.
That's it. Thank you. I'm going to stop sharing here.
So Unjali and I have not been able to track the chat. And I'm not sure questions, but I think we were going to sort of open it up to maybe hopefully some of the questions that were there. Try to address them as best we can.
Yeah, we have a few questions here. I'll pull up the first one. The first one says, I'm an Indigenous patient navigator. What is the best approach to get doctors to engage with learning cultural safety?
I think that it's really important to highlight the importance, but the people they're serving. So, and making sure that they know that that's why they're there. Like just a reminder of that's why we're doing the work that we've signed up to do and trained to do. And that it always comes back to the people that we serve. And so, you know, whatever training is required or reflection process is required or whatever that looks like, it's to actually do the work in a good way to ensure that people can receive it. So, Kelsey?
Yeah, and I think we continue to advocate and try to draw further attention to the topic at large. And we've got, you know, many of our partners, many of the senior leadership for many of our partners have, you know, signed on to declarations and or through MOUs, and it's being written sort of into other languages. You know, whether it's mandated or other, when it comes to specific interactions, kind of face to face with teams or those involved, you know, there's this challenge in terms of, do we mandate providers to obtain some level of cultural safety and humility? And you quickly run into some issues when you mandate somebody to do something. You know, we obviously want all providers to participate in this, to see value in it, maybe, you know, both for themselves, but more importantly for their patients and the populations who they're working with and serving. I think we have to remember, you know, the public is our boss, and then, you know, the public funds us, the public pays for this, right? So yeah, I think we kind of have to recall or sort of remember that, you know, when we sort of speak of those power dynamics, putting people's, you know, checking people's ego in at the door, trying to meet people where they're at, and supporting things that way. So there's a lot of work, and we're trying to create more resources to support people, you know, where they're at in terms of their cultural safety, humility, learning journey. You know, we know some are at the very early beginnings of it, and we want to be able to provide the resources to be able to support people at that point. Some people have undergone certain programs and courses and had other experiences, and they're looking for, you know, what's next? What do I need to help sort of complement and fulfill some of this work? And so that's where I think there's some of those committees and other works that are trying to really brainstorm and produce some products that do help people who may be a little bit further along in their journey. But it's a commitment. And so, you know, if you're an Indigenous patient navigator or liaison worker, you know, whether it's working in the regional health authority or if it's within BC Cancer or some of the other acute care facilities, much of the leadership is asking this and is looking to support their employees. And we haven't quite got to the point where it's been mandated, because I think harm can come with, you know, enforcing and making sure if you don't do this, you know, you're gonna, what's the consequences can be? You know, is that really the change that we're seeking? You know, we want people to enter this with a willingness to learn and to be open to those ideas. So I hope sort of our persistence in advocacy and that the responsibility and the ownership within our partners is really trickled down, you know, from top to bottom. So.
Our next question is, currently our healthcare system is not really set up to be inclusive of traditional medicines or alternatives. Are there any suggestions to help the current medical system change their views on this matter?
Again, I'd like to say yes, but it's also, I think it's revisiting some policies in some places, but it also, I think, just starts from change, like I say, within leadership. We've had a lot of commitments to this work from the regional health authorities, those in sort of the administrative positions, to try and support, when it comes to we've got the new standards that have come out. So our partners like in this space, so nurses in midwifery, the doctors of BC, other regulatory bodies are engaged in this work and trying to create the resources to be able to support those within their bodies to achieve. And I know on the quality side of things, trying to explore like what the definitions of some of this work would be, or what is it that we're trying to attain to. We often hear, we'll know our work is culturally safe and it's a good experience based on when our patients tell us so. But how do we track that? How do we document that? How do we collect that info? That's a little tricky. And we've got a lot of people who are trying to put their thinking caps on in terms of how we may be able to provide that feedback, so we can kind of gauge how we're doing, as a system, but how we're also doing, in regions or locally as well. We get a lot of community members of leadership, what's the so-and-so of my community? What's the numbers of this and that in my community? Trying to work towards, being able to give that information, but also, not just for community members, but also for the healthcare providers who work within those communities as well.
And with that, I think I always look at it as a circle of care. And so I always look at every touch point within the system has to represent those that it serves. And so everything, I know I've talked a lot about forms and things, but we've embedded on a lot of Mat-Child forms, what is important to this person that you're serving culturally? What do they need? Do they need a spiritual leader? Who do they need to be a part of these conversations? In consent forms, in loss forms, in antenatal pieces, in all of it, that we've really tried to do that. And so within any life care journey inclusive of cancer, it starts with our educational system, making sure that we're teaching this on to our learners, and to making sure that they know to open this space in conversations and in history taking, and moving away from extraction and moving towards conversational history taking and inclusion of things that are important to people. And then with those structural pieces of forms and all the things that our leadership is doing. So it really is, it's a 360. It's very much that all pieces of care have to represent those that we are serving. And so I think this is a key example, and it's one that I think we've seen some change on, but we need a whole lot more.
Thank you for that. Our next question is, I would like to learn more about how we might engage with Indigenous cancer patient navigators to support Indigenous clients in their lung screening journey. Shall I connect with Warren on this, or do you have any suggestions as to how we might work together?
I would connect with Warren. Easy answer.
Thanks, Warren.
If you're here, thank you.
And just a question from myself. So like working with families that have cancer screening, like what are some ways when they, like other than the patient navigators, like what are other ways to support them as Indigenous physicians working in the healthcare system?
Mm-hmm. I can speak as an ally and Black person in prison who's been a patient on the system for a long time. The thing that I think is of like extreme value is that open door. Like when there is, like there's going to be many questions that come from not just screening, treatment, and whatever the journey might be. And you need a safe space to ask those questions. And that open door is like, it's impossible to replicate, and it's vital to all care. And I think just having someone that you're familiar with be that open door is really important. So having, whether it is a primary care doctor or not, whether it is a physician or not, there's going to be someone who has health knowledge in a community that needs to be supported within a community. And I think that's one of the most important things that we need in our communities, more support of those open doors, and where people can just safely, and sometimes it's not necessarily questions, it's venting, it's just wanting to sit quietly, whatever it might be. We just need that safe space to be able to do that. And I think like that's something that I deem is really, really important in that question.
Yeah, I agree. And I find sometimes my approach with when I try to connect with people, like I say, particularly over the doctor of the day service, I'm connecting with people not often by telephone, sometimes by Zoom, but it's virtually, or it's telehealth. So I'm not in the same room, which can pose some challenges in terms of how do you connect with patients? How do you try and create safe space? And Unjali had mentioned earlier, sharing who you are, where you come from. There's a lot of different ways that we can try and explore just general conversation. If you had to meet somebody new in the elevator or at the bar or wherever, some sort of meeting, how might you start to connect with them? And it's rarely jumping in, hi, I'm a physician, how can I help you today? It's a little bit different. And in terms of, when we're talking about the upstream side of things, so more on the screening side of things, it's, what's important for your wellness, what's important for your community or for your family. And people start to understand or maybe appreciate what people value and how to approach it. And, and then we start to bring in some of the, well, have you thought about, how do you support your wellness? What kind of ways do you do? What are things that you do? Because sometimes we quickly, what do you do for activity? Well, I don't do, I can't be that physically active. I have certain restrictions or other things that prevent and limit that. And we know, people's health and wellness is far beyond just their physical capabilities. So when you start learning about some of these things, it's okay. You can maybe broach in, have you heard about any of these screening opportunities, whether it's a colonoscopy? Have you ever heard about somebody who's had a scope put in one of their, down on the backside, or whatever it may be? I heard a really bad story, or I have done this, or I haven't done this, or I've heard so-and-so. Oh, what did you hear? What does that make you feel? What do you start to explore it, and then you kind of narrow it, like, I think, defer to other, broaden it, start really, sort of like cast a wide net, and then maybe start honing it in a bit more to the individual and their thoughts and, their experiences or their hesitations or reservations around it, and unpack it, from a medical side of things. This is why it's important. And that's why we kind of say, if we do, we try and suspect things when people are feeling healthy and well, and that's kind of the whole idea behind screening. And if it does identify, these are kind of the next steps. This is what it sort of looks like. And, I walk through, and granted, it sometimes takes a few appointments to work your way through it. If I'm to explain a colonoscopy, sometimes people can get the 2-minute version of it. Others need to take it away and sit and think on it, write some questions, and that's okay. And come back and we sort of explore it again. So I like to try and start really wide. I like to try and just normalize some of the conversation and get an understanding of what people are doing, and then sort of maybe focus in a little bit more in terms of their, how they think of themselves in this. It's pretty easy when they, mom or dad or brother or sister or cousin over there, or, friend over there did this. Okay, now let's bring it in a little bit closer. What about you? Like, have you had this, or what do you think? So,
and bringing it back to that humanity too, of having a conversation. I have in my clinical realm dealt with very intimate care. So it's maternal child care, gynecological care, and it's okay to relate to someone. It's okay when someone says, I hate getting a pap smear, and you're allowed to say, me too. Like, you're allowed to be a human in these conversations, and you're allowed to say, you know what, I don't feel any differently than you do. How do we work together to make this okay? And it's important to let people know that you're on their side and that you're there as a human going through a journey alongside. And I think that gets lost in medicine at times, where there's more of maybe not a side-by-side relationship, but more of a head-to-head relationship at times with the system and the people in it, versus let's go together down this path. And even the posturing, like when someone comes in, this person should be treated just like they would be your friend, like just someone that's a part of your community, a family member. How do you want your parent or sister or brother or cousin to be treated in these appointments? You want them to be treated with love and with this wraparound warmth. And so that warmth is very easily lost in a healthcare system that often feels so sterile. And just be yourself. Like I'm a very casual person, as Kelsey knows, and I carry that into practice. And there are of course going to be people who do not want that, but usually people want someone who is going to be a friend, who will cry with them, who will laugh with them, who will feel their pain, who will understand their fears, and not say your fears aren't impactful or important, because that's a really big problem in healthcare. We don't give enough weight to people's fears and concerns coming in, and acknowledge and say, you know what, that is a real valid fear, and I get that. And how do we work towards making this a better circumstance? How do we work to make this better? And how do we make you feel comfortable? And what can we do to make that happen? So I think those are really important pieces.
We have one last long question here. It says, I'm a clinical herbal therapist and Indigenous patient navigator, and I was disappointed that the TRC natural medicine database I have access to within BC Cancer says inclusive data for some of the most well-researched plant medicines. Do you have any recommendations or advice for thinking about bringing in or leading clinical research / trials? I think Article 24 of UNDRIP could be a good way to back access to traditional medicines, considerate of herb-drug interactions, contraindictions, and I would love to advocate for our medicine, even if it's a few plants at a time.
That's a little bit to unpack. I think and forgive me but I think I understand it as kind of as we mentioned, the concept of two-eyed seeing in Indigenous ways of knowing in the practices and beliefs and things that we've had passed down throughout the years, and practices that we have applied, and blending it with the kind of the Western model of understanding medicine and how we apply it. How do we bring the two worlds together? How do we have some mutual respect, create the space that allows for either or both? And I think we've kind of heard some rumblings over the years within the cancer world. There's this skepticism or scary place to go in terms of allowing traditional or other modalities where you don't necessarily know what it is that's complementing, for fear or question that it maybe interacts in such a way with the Western treatments, if you will. So I certainly think there's space to explore it. I think there's a willingness, I've been able to connect with a few people from the BC cancer side of things. And I believe there's certainly a willingness to try and allow and create space for other, sort of non-traditional modality, or traditional for our peoples, but maybe not traditional within the Western medical model, if you will. In terms of how to approach exploring this or researching this or trying to integrate it, I think that's certainly a question we can take back to Warren and his team, as they are very similar to, I think, what we're often doing at large is supporting our partners, trying to have Indigenous people be placed within other organizations and start to plant the seed and see it grow and have it kind of make its way throughout the systems. So we try and influence from outside, but also from within. And I think that's very similar to something within BC Cancer. I can't speak, on behalf of BC Cancer by any means, but we certainly have Indigenous workers who are within that system, if you will, and are working up and below in terms of trying to spread their knowledge and understandings and create that kind of space. And I think this would be something that would be really important for us to take back to Warren, in terms of, are there practical ways that we can try and introduce this, or how do we sort of socialize this to try and ensure, and like I say, it's sort of mutual respect in terms of bringing different modalities to the table. It's like we say, community members will have different practices and different beliefs and different ways that they want their wellness journey to look. And if we're not even creating the space to allow for some of those traditional ways, I can't imagine it's going to be good outcomes, or it's going to be a good experience. So we need to find ways to allow for that and to create that. I can't give a definitive answer that and make a commitment on behalf of them, but we can certainly try and bring that to conversation and advocate that this is something that's still there. I know, like, bigger scope, we've also, is not just within BC Cancer, but we've explored, traditional healers and traditional medicines in terms of within the First Nations Health Authority, exploring this and as team members within our primary care groups, recognizing the importance that they bring to this work. There's some logistics behind it that get a little bit tricky. Trying to figure out which I'll put aside at the moment, but it's certainly on the table, and we are trying to figure out how to kind of best approach this. So it's a part of a bigger conversation, if you will, but we can certainly bring it to the conversations that Unjali and I have connected in the BC Cancer. I don't know, Unjali, do you have anything further?
Yeah, I think one of the starts to this is those conversations that can make people feel very uncomfortable, where there's something being brought into a care system that they themselves don't necessarily understand or have knowledge about, or have the history with. And I think we need to start those conversations sort of right away, to say, the system often puts people off and makes people not feel like they're a part of it or wanting to be a part of it, if it so happens that there's a discordance between provider, system, and person being served. And we want to make sure that's not happening. And this is one of those circumstances that I would identify as existing, where there's a lack of understanding, there's loss of comfort, there's this uncomfortable moment. And it happens a lot in the work that I do in maternal child changes and consent pieces, and along that line of, whenever there is that discordance, that's where that friction starts within a relationship. And that's one that we have to address. It's not just the physical logistical piece, but it's also an education piece of the not just importance, but safety and understanding and meaning behind it. And I think that's a really important piece, and definitely a conversation for us to have on our end and with our partners. So, because sometimes it can be so healing to someone to even have the conversation, be respected and heard. And I think that's a really important start. So.
Thank you for that. And thank you to our guests and everyone for joining us today. And thank you so much, Dr. Kelsey Louie and Dr. Unjali Malhotra, for an amazing discussion. It was great to learn about cultural safety, two-eyed seeing, and seeing some of the resources and supports that you guys have on your presentation. And just before we end the webinar, we'd love to bring your attention to our upcoming UBC Learning Circle. We have Everything is Health, a knowledge translation podcast with Maddie Elder and Nicholas Ubels. That's tomorrow at 10 a.m. Pacific Standard Time. And then we have First Peoples Cultural Council on January 26th at 10 a.m. Pacific Standard Time. And then we have Unlearning and Undoing Systemic White Supremacy and Indigenous Specific Racism with the BC Office of the Provincial Healthcare Officer. Sorry. That's on February 7th at 10 a.m. Pacific Standard Time. And yeah, so sign up for our newsletter. The link will be in the chat. All webinars are free to sign up for on our website at www.learningscircle.ubc.ca. Thank you everyone for joining us today. We look forward to seeing everyone at our next Learning Circle. Lim lived. Thank you.
Thank you.
Thank you, everyone.